Good morning. Welcome to In the Trenches with David Cohen. Today I'm going to be talking about cirrhosis of the liver. This is going to be a quick short talk on the problems with cirrhosis. Cirrhosis, there are plenty of causes of cirrhosis of the liver. One thinks of alcohol. Two other major causes to think about are chronic hepatitis C and fatty liver, causing NASH. There are other causes, of course, chronic hepatitis B, and then metabolic diseases such as hemochromatosis and Wilson's disease. But we're going to talk about the major things to follow with cirrhosis of the liver. So a patient has a known diagnosis of cirrhosis of the liver, and you could divide the problems into two categories. Problems related to the liver and problems related to portal hypertension. So these are the two categories. So let's talk about the liver problems first. The liver problems you have to think of are ascites and encephalopathy and hepatorenal syndrome. And there are other problems such as coagulopathy and a few other things. The major two are ascites and encephalopathy. Now, I talked about ascites last week. A few words on ascites. The mechanism of ascites with cirrhosis of the liver is increased intrasinusoidal hypertension, sinusoidal pressure. Okay, and in the space of this, you have proliferation of stellate cells, and they cause intrahepatic, intrasinusoidal hypertension. Fluid leaks out. It leaks out into the peritoneum. And with cirrhosis, you have, because of the vasodilatation, you have decreased effective arterial blood volume, which you get stimulation of the renin-angiotensin-aldosterone system. You get secondary hyperaldosterone. You couple that with oftentimes with advanced liver disease. You have low albumins because albumin is made in the liver, and it causes fluid to go in the belly. That's ascites. You have a cirrhotic who gets admitted because of increasing ascites. One thing you have to worry about is that they're not developing spontaneous bacterial peritonitis, and you do a diagnostic paracentesis, and if the PMNs are greater than 250, then you treat for spontaneous bacterial peritonitis. It should be noted, even if nothing grows out of the culture, you have something known as culture negative neutrophilic ascites, you still treat these patients also. The number one organism causing this is E. coli. That's ascites. Encephalopathy is the other problem. You know, as far as what the culprit is, it's long been thought to be ammonia. Ammonia is really a marker of the severity of the hepatic encephalopathy. It's not the direct culprit, and the feeling is ammonia goes to the brain and gets converted to glutamine, and glutamine causes cerebral edema. And there are different degrees of hepatic encephalopathy. It's staged. People might not be fulminantly encephalopathic. There's a low-grade hepatic encephalopathy, which is the equivalent of like an individual walking around with an alcohol level of 0.8. But this is really the other major problem. Now, as people with cirrhosis get sicker and sicker, and often these people are on diuretics to treat ascites, what happens is they could develop diuretic resistance, and then they could develop hepatorenal syndrome. There are two categories of that. There's type 1 and type 2. Okay, type 1 occurs over 2 weeks, and it's more fulminant. And basically, you know, if you autopsy these people, their kidneys are normal. It's due to abnormal hemodynamics. They get tremendous splanchnic vasodilatation. And in compensation for that, you get vasoconstriction, of other blood vessels, including the renal arteries and arterioles, and you get intense renal vasoconstriction, and that's why they develop a decreased GFR. Let me talk about the portal hypertension problems, and then we could go say a few words about treatment. And portal hypertension could be caused by conditions other than cirrhosis of the liver. It could be caused by portal vein thrombosis and other conditions. But with portal hypertension, really the major problem is developing varices. And a varice is a juncture, is a connection, an opening between the portal and systemic circulation. And normal portal pressure is about 5 to 8 millimeters mercury. And when it goes greater than 12, these varices could open up. Okay, when the varices open up, you worry about varices occurring in the esophagus, gastric, rectal, and umbilical. These are the 4 locations. Esophageal are the most serious. Esophageal bleeding is a cause of demise in many patients with cirrhosis. They could also develop gastric varices. They could also develop something called a portal gastropathy, where the esophageal veins, they're somewhat dilated, but you don't have frank varices. You could develop hemorrhoidal varices, which are different than the more common type of varices, and you could bleed to death from these. Or could they develop umbilical vein varices manifested on physical exam as caput medusa. The only other problem with portal hypertension, you can develop splenomegaly. And you could develop, these people have big spleens, and you could get sequestration, you can get thrombocytopenia, and you could get anemia, neutropenia, so they could develop splenomegaly. So let's talk about how you approach the treatment of these conditions quickly. If somebody has ascites, you're going to restrict their sodium intake, possibly put them to bed rest. You're going to treat them with diuretics. The most important diuretic are aldo receptor blockers like spironolactone. If you give a loop diuretic without that, you could get profound hypokalemia, you could get arrhythmias, it could also precipitate hepatic encephalopathy, because these patients have secondary hyperaldosteronism and their aldo is already all revved up. So you're going to give them aldactone, spironolactone, and then a loop diuretic. If that doesn't work, the next thing that you might do in these patients is a large volume paracentesis, where you take off the fluid. You have to be careful, and if you're taking off greater than 5 liters, you're going to infuse albumin. Otherwise, you could get hypotension. There's a condition called post-paracentesis circulatory dysfunction, where you can get vasodilatation. Now, if the diuretics and the paracentesis large volume do not work, sometimes you have to proceed for procedures such as TIPS, transjugular portal peritoneal shunting. The problem with this could make hepatic encephalopathy worse. Moving along, how do you treat hepatic encephalopathy? The gold standard is a drug called galactulose. Okay, it'll convert ammonia to NH4. It increases the stool frequency. You'll poop out the toxins. You also convert NH3 to NH4, and it may inhibit synthesis of some of the bacteria that produce ammonia. Another drug that is now used, the second line, is Xifaxan or Rifaximin, which you can take orally, and it works at the GI tract. It does not get absorbed. It does not get absorbed systemically. As far as treating hepatorenal syndrome, that's a serious condition. These patients often require to go into the ICU. They used to use vasopressin. There's an analog of that called terlipressin, okay, which vasoconstricts the splanchnic vasculature and shuts off the compensatory mechanisms. Sometimes you also use octreotide somatostatin, which works slightly different. Nevertheless, it works. As far as treating varices, you make the diagnosis. number one prognostic factor, whether a virus will bleed or not, is the size of the varices. Okay, normally GI goes in and they do banding. That's the treatment of choice. We used to use more vasopressin, and these football helmets we would put people on called, which had compression tubes, or called Blakemore stacking tubes. I have not seen one of them put in probably over 30 years, but it's usually procedure mediated. It should be noted, after a cirrhotic bleeds with varices, or if they have any type of bleed, you need to put them on antibiotics to prevent sepsis, bacterial peritonitis, and also gram-negative bacteremia, because you get transitation of bacteria in there. If somebody's liver function is really severe, the ultimate treatment, provided they're eligible, may be a liver transplant. The score that's used is the MELD score, which takes into effect the bilirubin, the prothrombin time, and the creatinine, and more recently the serum sodium was added to this also. That's called the MELD NA score. In other words, patients with cirrhosis could get coagulopathies, but they could still have blood clots. All the factors are made in the liver except factor VIII and tissue factor, but you often make enough for these to clot. So even if the INR or the PT-PTT are prolonged, it doesn't mean they're not going to develop a blood clot. And with that, I am going to stop. We're in the trenches. Thank you.